Hi, I'm Solome Tibebu, the host of the Behavioral Health Tech Conference, and I'm very much looking forward to this exciting conversation around behavioral health, quality care, and so much more. So to get started, would love to ask our panelists here to introduce themselves. Let me start, Julie and then Tom, please.
Sure. Hello. I'm so pleased to be here. My name is Julie Seibert. I'm a senior applied research scientist with NCQA. I focus on behavioral health and the behavioral health strategy at my organization.
Hey, everyone. Thanks for having me, Solome, and having us on this. I'm Tom Tsang. I'm the founding CEO for Valera Health. I'm currently the Chief Strategy Officer, and Valera Health is a comprehensive telemental health company that serves patients across the spectrum of acuity.
Thank you both. All right, so jumping right in, what exactly is the status of behavioral health and quality care today? Julie, I'll start with you again.
Sure, Salome. Well, I think before we talk about that, it's really important to give a little bit of background about the impact of behavioral health in the United States today. We all know that during the pandemic, mental health needs skyrocketed. I think we've seen studies that show that anxiety and depression increased by about 25%, and the rates have not resumed prior pandemic. We're also unfortunately seeing a lot of opioid involved overdose deaths. The number of deaths has exceeded 80,000 in the United States, and there are clearly treatment needs there. Finally, we're also hearing the suicide have increased in the United States as well, and they've reached record proportions. So clearly there is a demand for behavioral health, and clearly there's a need for quality care.
I would add and second Julie's list of statistics. I think since the pandemic, we've seen behavioral health visits probably go up as high as 20% across the marketplace compared to pre-pandemic numbers. And part of it is the fact that depression and anxiety have increased by 45% across the board. But part of it is also, I think there's a bit more destigmatization of mental health in general. And that's through a variety of social media, of folks coming out and saying, go get help. And that's a good thing. But I think there's definitely more work to be done in that space. But in terms of going back to your question about the status, I think this is really super exciting time for all of us because of this increased number of visits, increased demand, increased utilization. I think it's incumbent upon all of us to really ensure the highest of service, the highest of and highest excellence in terms of quality and outcomes and safety. And more recently, CMS, which basically controls Medicare and partially Medicaid from the federal government, they came out in 2022 with the CMS National Quality Strategy. And really, that shows that the largest purchaser of healthcare, which is the federal government, they truly want to revamp how we all define quality in regards to patients and to providers and to healthcare organizations in general. And they focused on 4 domain areas, which all of you can look it up. One of them is outcomes. Another is equity. Equity is considered a quality domain area. The third is advancing scientific practices and knowledge. With this recalibration of what the national quality strategy is for the country, I think all of us who are stakeholders and part of that ecosystem needs to read the signals and also do a quality strategy assessment within each of our organization.
Speaking of which, quality strategy at each of your organizations, would love to hear a little bit more about what that looks like for both of you. Maybe Julie, I'll start with you again, please.
Sure. I'd like to provide a little bit of background about my organization. I work for NCQA, which stands for the National Commission on Quality Assurance. We're a nonprofit organization based in Washington, D.C., and our goal is to improve healthcare quality across the United States. We do that a couple of different ways. One of the ways that you're probably most familiar with is HEDIS measures. I think folks have heard of those. HEDIS means healthcare effectiveness and data and information set. And these are measures usually based on claims or encounters that are standardized, and they're used to compare health plans against each other. And they can look at the performance of health plans. The other service that we provide is accreditation and recognition programs. These are for health plans and provider organizations. And actually, we serve as like an impartial reviewer, and we can evaluate the quality of an organization and also make sure that they're high quality and make sure that that they're upholding national standards. The final thing that we do is we provide a great deal of education about how to conduct quality improvement and how to involve in quality projects within organizations. But one thing I also want to talk about that I'm really kind of excited about is NCQA has developed a behavioral health quality framework. And I'll just talk about it as a high level. The goal is to use measurement-based care or measurement to promote joint accountability and whole person care in behavioral health organizations and at every level. One component really is just to identify priority goals and priority populations. That could be related to what I was talking about earlier. It could be related to opioid use disorders. It could be related to suicide prevention. It could be related to children, any special population. The other component of it is really just to choose the right tools and strategies. And that means developing bundles of evidence-based measures and metrics and then aligning them across the system. We also, a component of that would be publicly reporting these metrics. So, and reporting them at each level, reporting it for the provider, the health plan, and also nationally. So you can see national benchmarks. And then finally, and I think probably the most important part of this quality strategy is to kind of facilitate alignment of policies and payment to sustain that behavioral health quality. Everybody knows we need some improvements in behavioral health financing. For a long time, there really hasn't been enough funding, particularly in the public sector. We'd like to see some improvement there, and also investment in behavioral health data infrastructure, and finally some investment in the behavioral health workforce. And a lot of the work we do here at NCQA is in support of those different things I outlined.
Any which one of those things are major. Phenomenal. Thank you, Julie. And Tom, same question for you. Would love to hear a little bit more about how quality fits in at Valera.
Yeah, so Julie gave a very, very comprehensive overview of what NCQA does. And I want to really give context of how we fit in relationship to all the stuff that Julie said. So I would say NCQA is kind of like the gold standard steward of what quality is and how we define quality. We've all believe in NCQA as the steward, right? And so all the health plans, including the federal government, including the state government, including the health plans and the providers, have put our faith into NCQA as the arbiter of what quality is. And so we've all accepted NCQA's definition of those behavioral health measures. And I'm coming into mental health as an internist. I'm not a psychiatrist. So I've always used this phrase that what we can't measure, we can't manage. So you got to measure what you manage, right? And so it was easier for me as a primary care doc way back when people looked at my care as an internist and said, oh, how many times have you measured a diabetic's HbA1c? Did you measure their glucose, fasting glucose, twice a year? And if it was high, did you follow up with a ophthalmologic exam or check for protein in their urine? So those are measures in diabetes care, and those are partially a list of process measures and outcome measures. So I kind of took that philosophy and the number, I won't tell you how many years I've been in healthcare or else I'll be dating myself, but basically the years of understanding what quality is in the internal medicine realm and what NCQA advocates, and really built a comprehensive quality strategy using that philosophy, using those behavioral health measures, and really ingraining it into Valera's DNA. And so we have a comprehensive strategy where we ask our providers and our clinical leadership team, are these measures that we care about? Do we want to measure how someone would do with our therapy and medication in terms of their depression? And if yes, let's use standardized measures that NCQA has put out. And so we can compare ourselves, how we do compared to the rest of the industry. And so we use NCQA measures. Our quality strategy is built on NCQA measures, including the depression response rate, which is 50% reduction in your PHU-9 after 3 months to 4 months of treatment. And we also look at, if you score very high on the PHU-9, do you follow up? So we have a very comprehensive measure set. We look at our results on a quarterly basis, and then we do cycles of where we look at different various interventions to see how we can improve. So that quality strategy is ingrained in all of us, and we ask our providers to take part in that process. And it's a iterative process because there's always room for improvement.
That's great to hear everything that Julie had just discussed, you really putting it in practice with the care that you're delivering. Thanks for that, Tom. Now, both of you made me think a little bit about, could you go into a little more detail around what these main factors are that are actually impacting the quality of behavioral health care delivery in the U.S. today? I think that could be really helpful and eye-opening, candidly, for our audience. Maybe Julie, I'll start with you again.
Well, sure. I think I'll talk about two, and then I'm sure Tom can add more. The first thing I think about is access. Access to care. We're hearing there's not enough sufficient workforce. It's very difficult to access a psychiatrist or someone who can prescribe. It's very difficult to find someone who can diagnose. I mean, I was looking at some data, and I think actually 50% of the United States is in a behavioral health workforce shortage area. So that's rather large. So access is a really big thing. I think one of the great things, just the rise in virtual care, I think, has been really, really helpful in kind of improving that access, but still there's probably a little more work to be done. So that's something that NCQA is looking at, is trying to develop more quality measures or standards regarding access. There are no national network adequacy standards currently, and that's one thing that we're looking at. Part two would be, data and data accuracy. A lot of behavioral health providers were left out of the HITECH Act. which means that they do not have access to funding and kind of the support for EHRs. So that's kind of an issue in being able to kind of pull data and evaluate practices. So I think that that's a large problem for a very specialized segment in behavioral health. I think those are the two largest issues, but I'm sure Tom has more to add.
Well, I want to give an example because I think giving examples is a perfect way to really understand the context of this. And specific to Julie's point about data, there is a measure called medication adherence. So the numerator is if you have a chronic illness, such as, let's say, schizophrenia and bipolar disorder. So this would be the medication adherence for antipsychotics. I think the numerator is, don't quote me on this, is like 100, and have you been taking the medication over like 180 days over 270 days or something like that. So I don't think we've had the data as a provider to really understand adherence. So adherence in to what I understand is if the patient picks up the drug from the drugstore, that is data that's being used as adherence, right? So, but we don't really know whether the patient, even though they pick up the drug, they're actually taking the pill on a daily basis. They could be picking up the drug and taking it Monday, not taking it Tuesday, taking it Wednesday, not taking it Thursday, because we physically don't watch them take the antipsychotic. So that's one. So there's really, it's not a perfect world and it's not a perfect system. And so there are imperfections to these measures that we still have to kind of get right as an ecosystem of stakeholders. And the second thing is, do we have measures that focus more on outcomes than process? We constantly measure processes. That's great. And I think there's room and place for process measures. But ultimately, we want to measure, how does the patient feel? Is the patient happier? Is the patient being able to live their lives symptom-free? And if it's not symptom-free, can they live their lives doing what they want to do, at least tolerate some of the symptoms and tolerate their condition and living with some of the conditions that they're living with on a chronic basis? Because you can't cure schizophrenia, you can control the symptoms, right? And so how do we come up with measures that truly are meaningful to the patient and that is impactful to their life? So my point is, the measures need to be improved. It's a constant iterative process to improve these measures.
These are excellent examples. And of course, if providers can meet measures, something both of you have alluded to earlier is that providers in the behavioral health space can be rewarded with that quality care through payment. But one thing I want to ask both of you is, what is it going to take for, or maybe how would you define readiness for implementation of value-based payments in the behavioral health system look like?
Oh my God. Let me go first. I think we've been talking about value-based models for as long as I've been in medicine, and this is at least for the last 30 years. We've been talking about value-based models longer than you've been alive, Solome. I'm trying to be an optimist. I'm trying to be the glass half full guy here, and I think every single year we're inching closer to the goalpost. And I think what we're seeing is better measures, the fact that we actually have Julie here and there is a Julie in NCQA means that NCQA is giving priority to behavioral health. Like, her job exists. She is here. She's talking about this. And that's, an accomplishment, right? And so if NCQA is paying attention to this, it means that the health plans are paying attention to this. And so it means that there is a rising tide for hope and glimmer that this is going to be reality and that more and more health plans can take part in this. So I'm not so sure it's organizational readiness. I think it's national readiness that we're talking about, that there are health plans there now talking about how can we come up with attribution models? How can we give attribution to behavioral health providers that global total cost is impacted by behavioral health outcomes, that the diabetic who is depressed and eating a pint of Haagen-Dazs on a Friday night does cause an increase in total cost of care, which send them to the hospital and the ER because of hyperglycemic episodes of sugars of 700 because they're depressed. And that depression is causing a 3x in that diabetes total cost of care. And that we could figure out a way in being part of that value-based model discussion. And I'm hopeful that it's going to happen before I retire.
Sure. I guess the only thing I'd add, you talk about attribution and there, I don't know what we've decided yet, but there is some talk about, joint accountability and shared accountability. But you're right. I mean, in the specific example that you provided, someone who has diabetes and a mental health disorder, if an event like that occurs, an adverse event, who's responsible? Is it the primary care doc or is it their mental health provider? And how are we going to slice and dice that to see, who is responsible? And you're right, we're not there yet, but I'm hopeful that that we'll, as we get more data, we'll have a better understanding of the right population that needs to go into each measure denominator, and we'll be able to craft the right measures, and all of this will support value-based payment. We're on our way.
Okay, on the way. And I'm an optimist, but now if I could ask you each to just double down, like, what is it really going to take to move the needle?
I'll just start, I'll just go back to the quality framework. I mean, I'm a firm believer in kind of alignment from the provider to the plan to the payer and other policymakers. I think CMS took a really, really great first step in the universal foundation measures, which they are using to have alignment. And several of those measures are HEDIS measures. I'm very proud to report. Some of them focus on behavioral health, but I really do go back to that quality framework and alignment and using the same measures if at all possible. Understanding some of the measures are imperfect, but it's a way to start.
Yeah, I would say there is a lot of buzz and a lot of activity and momentum around that CMS universal foundation. And particularly, they mentioned a behavioral health measure that is asking the patient to talk about their self-care goal and whether they have reached that goal as an outcomes measure. And so that gets to the point of a patient-reported outcome measure perspective, that we're engaging the patient in what is meaningful in their lives, as opposed to taking a medical paternalistic viewpoint of we the provider defining what is important to the patient. Here, the patient is defining what is important to him or herself. And so I think these discussions are really informing that the field, health plans, CMS, and providers are really moving towards defining how do we truly define outcomes. And so once that is gaining momentum, I think the needle will be moving. I think there's also legislation, to Julie's point about EMR incentives. There's been legislation on the federal side in getting EMR incentives to the behavioral health providers, and that's going to kind of move the needle in getting data interoperability amongst behavioral health providers and allow for this measurement strategy. And then I think lastly, policy is going to impact a lot of this, and we see at least in the safety net provider, community-based provider ecosystem, we're seeing a lot of CCBHC funding, and that requires an amount of quality measurement in that sector as well. And so we're seeing a convergence of different types of activities that's moving the needle.
Okay. Yes, all really important initiatives, but one that we haven't touched on just yet, and of course, being a digital technology and innovation conference, I have to ask about, is where do you both see the impact of technology on the quality of behavioral health care?
I'll start. And prior to working at NCQA, I worked for the state of North Carolina, so I was in the public sector. And I really saw how the use of telemedicine or telehealth really had a huge impact on access. And obviously the pandemic really kind of was a disruptor and really kind of moved that forward. But I just can't, I think that's had the biggest impact. And the state and the federal government, who were very resistant to paying for those types of services in the past, really have changed their course. And I really think it's had a huge impact on quality, particularly access.
Well, this is going to be sounding like a gripe session, but I think a huge part of this is interoperability and access to data. At the end of the day, yes, we're all using EMRs, but the problem is we don't share that data enough. And so let me give you an example again. So there are two HEDIS measures. One is if a patient was hospitalized for a psychiatric diagnosis, are you going to see the patient within 7 days as a follow-up, right? And then the second measure is if the patient went to the emergency room, did you follow up within 7 days also after their discharge from ER? Now, we, as the most downstream of all stakeholders, we don't know if our patient is hospitalized. Like, we ask to be notified by the health plan because the health plan may know in advance. But in order for us to get notified, it takes about 5 days. So by the time we actually contact the patient, it may be the 6th day. Now we try to do a workaround, and we try to plug into a regional health information exchange organization, but it required about 3 months or 4 months of technical work just to plug them in. Now, we're fortunate that we have the resources to do that, but how is a solo practitioner able to do that? They can't. There are vendors out there, but then you have to pay thousands of dollars a month to plug into an information exchange, and that information may not be necessarily correct. So such an important thing and such a what you may think is a simple thing of getting notified that your patient is hospitalized. We can't have access to that data. Like, we have to do better, and we could do better. We just haven't quite figured out a way how to make that data accessible. And then similarly, like the medication adherence, I don't know when a patient picks up their meds or not. We have to call and call and call. So again, I think we're getting to the point where I think some of the measurements and some of the quality controls are related to access to analytics and to information. And the more we have actionable data, the better we can do this.
This has been a really great discussion, but I realized I didn't even ask you both, what is measurement-based care, and how, of course, could that impact the quality of behavioral health delivery? Maybe Julie and Tom, I'll start again.
Julie, you go first.
Oh, sure. I'm happy to do that. So measurement-based care is actually an evidence-based practice, and you use systematic assessments of a patient's perspective and patient's progress and outcomes. And it focuses on things like symptoms and functioning and patient-reported issues. And this is a way to inform the treatment process and engage the patient. I think it really does help the quality of behavioral health care, because it's a way for the patient and the provider and the health plan to get data on how a patient is actually progressing. And it's a very, we'd like to see more of it happen in the field.
Yeah, I think, again, I'll give you a practical example. We all, we all use antipsychotics for folks with schizophrenia, bipolar disorder, and there are risks to those medications, and it may increase your propensity to develop high cholesterol. You may gain weight, and some folks, it may increase your risk for developing diabetes. And so there is a measure out there that says, after 3 months of antipsychotic use, did you, the provider, check their cholesterol? And did you check their sugar level? So it's a process measure. And it works. It's a reminder that, did you practice according to the standards of care, right? And so I think that is going back to what I said. You can't manage what you don't measure. And although providers may hate this, we kind of know that it works, because you need the data. As a scientist, as a clinician, we work with data. This is not 100% art. It is a mix of art and science. And what NCQA does, and what the other organization, the National Quality Forum, NQF, they take the science and they convert it into these measures. And this is something that's been embedded in me as an internist, but we have to start doing that for the behavioral health ecosystem as well.
Excellent. Really great examples. I mean, this whole conversation, just hearing the way that NCQA has designed the measures and why you did the way you did, Julie, and then the real world implementation, Tom. As we are moving into some final comments, I want to be sure to ask both of you, how do you ensure the patient voice is embedded within quality and of behavioral health care? Whoever wants to tackle that one first.
I'll try it first. So NCQA has three different venues that they're ensuring patient voice. One is, we've alluded to the fact that we are responsible for the HEDIS measures and we are developing them and updating them. So we make sure that we do have patients involved in that development process and they're giving us feedback. Very necessary feedback, so we make sure that the measures don't go too far astray. So that's one way. Another way is we have embedded like CAPS. This is another acronym for you, but it's Consumer Assessment of Healthcare Provider Survey. We've embedded that in our accreditation process. And this is a patient experience survey where they're able to tell you, I was seen in a timely manner, or, my provider treated me with respect. It's a way for the health plans and the providers to be evaluated on how they're including and responding to patients. And a final thing that we're doing at NCQA, Tom had alluded to a little bit earlier, that we have something called patient-centered outcomes. And this is a measure that we're developing that we hope will become part of the HEDIS set. And what it is it's the patient and the therapist work together to develop a patient-generated outcome. And it can be something as simple as, having a sober Thanksgiving, or something simple like being able to see my grandkids, or it very, very, very personalized, and the patient and their therapist can work on that. We're currently, they were originated in long-term services and supports in the aging community, but we're currently testing them in what we call CCBHCs, or behavioral health setting. And we're finding that it's really increasing patient engagement, and again, is including the patient voice.
Yeah, I see where we've been going over the last decade, and I see the increasingly, I think stakeholders are really understanding that patient voice is important. And it's fantastic with what NCQA is doing, along with CMS and other policymakers, in making sure that it's represented.
Thank you both. Many of you who have heard me talk about my own experience, that I am not a technologist or a clinician, but I've come to this space as a patient, and so appreciate both of your perspectives on that front. And really, overall, this has been so eye-opening. Really appreciate the opportunity to ask both of you my hard-hitting questions here, but super helpful. And thank you for taking the time and sharing your expertise with all of us.